All right, so indications. When should you put end-tidal CO2 in place? We've kind of been talking about it and why that should happen. So when you have a ventilation problem, a Q perfusion problem, or the uncommon time when you have just elevated CO2 production or less CO2 production. So on the left there is everything, and on the right here is split into high versus low, right? So when would you have a low end-tidal CO2? When would you have a high CO2, right? So this should make sense. We just work through it real quick. So ventilation problems, right? So ET2 placement, that's a good reason to know that I'm ventilating appropriately, ventilating my lungs. They should have an end-tidal CO2 waveform, and they should have a number, right? If I don't have one, I'm not in the lungs, right? So I can know if I'm extubated. I can know if I'm in the esophagus. Okay, so it can detect disconnects really rapidly, right? Your ventilator's alarming, and then someone tells you, hey, your end-tidal CO2 is flat. It's like, oh shoot, I got to hook up my patient. Okay, so it can tell you if you have adequate tidal volume, right? So if your tidal volume was set at 400, and your ventilators are smart, and it will say, I accept your number, but it's not my reality right now. I'm going to adjust it based on the pressures in the chest, right? And the pressure in the chest keep going higher and higher and higher. It's not going to deliver 400 because it's smart about it. It'll deliver like 200 or 250. And you can see over time your end-tidal CO2 start going up. It's like, why is that happening? And you can look back at the tidal volumes and see they were dropping. Okay. Accurate respiratory rate, right? So everybody has a respirator at 18, right? Until you hook them up to a ventilator or an end-tidal CO2 or a BiPAP, right? Then it's no longer 18. Oh shoot, they're breathing 32 breaths a minute, right? Yeah, they're a little sick, right? So it's an accurate way you can capture that with a cannula as well, all right? So that means also someone on the flip side, right? They're breathing, they're 18, but you can really look at it as like, no, they're breathing like eight breaths per minute. So you can throw a little cannula on them and you can measure their end-tidal CO2. So who might be at risk for hypoventilation that should have the end-tidal CO2 that's not extubated? One of these guys here.
Over-medicated.
It could be over-medicated, someone getting like a PCA pump. This is kind of why PCA pumps are discouraged, but also someone that is post-procedure, right? Any post-procedure patient needs to have end-tidal CO2, right? Any bedside procedure, definitely. In the PACU, they measure this for for recovery. So you want to see if their end-tidal CO2 starts climbing. That means they're not breathing, right? Post-anesthesia gas or post-propofol infusion or post-versed for conscious sedation. Okay.
Do the GEs accept the side stream?
Mm-hmm.
Okay.
Yeah, you just attach it to it splits. One goes to it's the wall for your O2 flow meter, and then one goes to your your adapter right there, to your little water trap. Okay. So hyperventilation we've talked about, right? And a patient that is breathing fast, right? We don't want the end-tidal CO2 to go way too low, less than 30. That's a little bit too low, right? That can cause some problems, right? Especially neuro patients. All right, so avoid greater than 45 as kind of a rule, right? Unless they have some reasons for it, right? They have high CO2 as a baseline. That might be a reason. But getting a trend is a way to know if we need to intervene, right? So you have obstructive sleep apnea patient, and the CO2 sits at 45, and now it's like 55. It's like, oh, wake up. I'm going to put you on BiPAP, right? We can get an order for BiPAP and try this, right? We talked about conscious sedation, procedural sedation can cause hypoventilation. And psych patients, right? Psych patients, they got too much. They got the vitamin H, vitamin A, vitamin C. They got all the vitamins, and now they're just there. It's like storing up a storm, right? And you got a security guard there. You got 4 restraints. It's like, oh, they're good. And you give a shift report, and then they arrest. I can't tell you this amount of times that's happened. Or we're going around on rounds. Like, oh, are they breathing? It's like, yeah, they were storing a minute ago. So you want to make sure we have the end-tidal CO2 for these guys as well. And airway patency, we can look at the monitor and see, oh, you got a bronchospasm happening. Let me get your breathing treatment, right? You can see if they have air trapping. You can see if there's an obstruction, right, in the airways. So they're biting on their tube. You're not going to get a waveform, right? So why don't I have a tracing? It's because they keep biting on my tube.
Do we need an order for that?
For end-tidal CO2, no, it's standard. So end-tidal CO2 does not need an order. All right, so then perfusion. It's non-invasive. So usually if it's non-invasive, you can really, it probably can be, doesn't need an exact order. Well, with BiPAP, and you can't do everyone because BiPAP doesn't really have a good way to attach it because it's going so fast. And but Vapotherm is going way too fast too. But cannulas, if they require 8 liters or less, we can throw them on this cannula. Okay. All right, so perfusion. So that's all ventilation stuff, now perfusion stuff. So if they have cardiac output, not carbon monoxide, cardiac output delivers our CO2 to the lungs. So the cardiac output is poor, you're not delivering CO2 to the lungs to exhale, right? So that's a good way to trend. So my end tidal CO2 is 30, and it's 25, and it's 20. They're not breathing fast. The vet said at 18. Why are they breathing fast? But they're not. You realize that you check your NIBP and it's line/line, and you check it again at 15 minutes, line/line, and my end tidal CO2 is now 18 and then 12. That means your patient doesn't have a blood pressure, right? So it's a way to, in real time, know what their blood pressure approximately, that they're getting a blood pressure, I should say. Okay, so cardiac arrest, it's important. It'll tell you if you have effective compressions. When you're doing CPR, your end tidal CO2 by 8 to 10. As long as that's there, you can say you're doing good compressions. Keep it up, right? If someone's not doing good compressions, you're going to see the end tidal CO2 go less than 8. Okay, and then once you get ROSC, once your heart starts beating, right? Because CPR is not very effective. We try our best to compress through sternum and everything to get perfusion, but once your heart starts beating, it's really going to boost up the flow, right? And you're going to see that boost. You're going to see about 14 points of boost, right? So you get a end tidal CO2 during CPR of 8, and you get 14 points, 22. You got ROSC, right? So you can stop compression at that point. You don't have to wait. You don't have to wait to the pulse check, right? And definitely, if your end tidal CO2 is 30, right? You've restored ROSC. Okay. So shock states, hypotension, sepsis, cardiogenic shock, obviously, are going to have a lack of delivery of CO2 to the lungs, right? A PE, all of a sudden, yeah, that can drop your end tidal CO2. Okay, so we can look for like a response to treatment. I gave pressors and their end tidal CO2 went up. It's like, well, that makes sense. I can see my map right there. It's improving. Okay, and then some of the weird stuff. So metabolism, right? CO2 is only produced one place in the mitochondria. Why would I have mitochondrial dysfunction? Well, like there could be some, like they could take some, what is it? They have, what's the medication? The nipride that we don't use anymore. That can destroy the cytochrome system. But malignant hyperthermia, right? Like our gentleman over here, he's, his CO2 is going to be climbing because his cells are like firing off multiple times, right? The muscles are massively overworked, right? And they're producing a whole bunch of CO2. And yeah, he'll probably respond by breathing faster, but we'll be able to see the CO2 start peaking. Because if someone's breathing fast, they should have a low end tidal CO2. So why is his CO2 high? So that's kind of the part of the puzzle there, right? And then sepsis, that just makes our mitochondria not work, right? So that's going to cause problems. Fever, we talked about. Neuro patients are important to just monitor in meantime. So make sure the end tidal CO2 is not more than 40. Because CO2 is a vasodilator, right? Acids disrupt muscle function. Actin-myosin can no longer contract, and they start relaxing, and that's in the brain. That's a closed space. If someone already has a high ICP, that's going to raise the pressure in the brain and worsen outcomes. So we want to make sure the end tidal CO2 is at less than 40 for all neuro patients. Right? Pain patients, they can have increased VO2, increased production of use of oxygen, increased CO2 production. So that can also be an objective way to measure someone's pain. Hypothermia, is that going to be a lot of CO2 or little CO2?
Hypo.
Mm-hmm.
Depends.
Hypothermia is going to cause because your cells are going to start shutting down, right? The BMR is going to be lower and lower and lower. So BMR is the production of CO2. So CO2 will be low in hypothermia. Shivering, on the other hand, will be higher, right? Because their muscles are using a lot of energy, and when they use energy, they use oxygen, they use glucose, and they then punch out CO2 and heat, right? And then bicarb pushes. So if you get a little bicarb push, right? We know our formula from the last section, right? Bicarb is given. Well, that's just the reverse of my CO2 equation, right? CO2 and water makes bicarb hydrogen ions. I provide bicarb. That's going to bind with hydrogen, right? That's why we give bicarb pushes, to neutralize acidosis. So we neutralize it, and it's going to turn into CO2 and water, right? And that's going to then make its way to the lungs, and it's going to be exhaled as CO2. So it's like, hey, why'd your end tidal CO2 jump from 25 up to, or let's say 20, because they have poor cardiac output, up to 32, right? It could be improving cardiac output, but it could also be just due to the bicarb pushes I gave, right? But when you give a bicarb push, they have to be able to breathe, right? So this is why it doesn't make sense to give bicarb pushes in cardiac arrests, because they're not really breathing. So if you give bicarb push, it's going to neutralize the hydrogen ions, and it makes more CO2, which is carbonic acid, and it's going to the lungs to get rid of it. I can't because I'm not breathing. So then it worsens the acidosis. So this is why bicarb is not indicated in cardiac arrests, right? There's only really one reason for it, and it's if someone overdosed on TCA antidepressants. There's no other clinical reason for it, right? You can try like last ditch effort like at 25 minutes in, but it's not indicated. It doesn't make sense physiologically, and doesn't make sense, practically as well, and with evidence. All right, so the different reasons for end-tidal CO2. We've kind of talked about this, but just kind of explain it a little bit more detail. The esophagus being intubated, right? If you intubate the esophagus, you're going to see your waveform start to go down, right? So you might get a little capnostat reading right there. So, oh, I'm in the right place. But then once you hook it up to the monitor, you're going to see 1 breath, 2 breaths, 3 breaths. Definitely by 6 to 8 breaths, you're not going to have any more CO2. Okay, so after 7 breaths, right, that's usually, you can get another capno check, right, take this one off and then put another one on and see if we have we're still in the right place, if it's still yellow. And what color do we want it to be? Gold. All right, that's the one we want, okay? And then capno checks, easy checkups, they just check that there is acid present. It doesn't know that it's CO2, doesn't know anything. All it knows is that there's acid present, right? So esophageal intubation, we want to be looking at, we'll see a downtrend like this, all right? And then sometimes you have, someone puts the end-tidal CO2 up, say, I don't need that. I got the best ears known to man. Move aside. And I got the best stethoscope is the ETCO2 4.5. Just move aside. And they're going to listen, right? All 5 spots, left, right, bases, and stomach, epigastrum, and say, yeah, it's the right place. Well, guess what? 15% of the time is wrong, right? So what's not wrong is the end-tidal CO2. It's 100% accurate. There's no other case scenario where it would not be accurate, right? As long as you have waveform capnography, you are in the right place, right? Because your stomach does not produce CO2. Right? If you have a Diet Coke, after 7 breaths, the CO2 is gone, right? But over here, listening to the stethoscope is not as good as hooking up to the capnography. Okay, so that's the idea, and this is a summary. Remember, this turns yellow, and there are different sections that can estimate what your CO2 is, right? If I'm barely getting the color change, say, yeah, it's because they're super hypotensive. I'm not expecting a really, really bright yellow. Okay, and then how would you confirm that? I throw them on the monitor and say, yeah, end-tidal CO2 is 22, but I got a nice waveform. I expect that. Let's give some pressors. Let's get that blood pressure better, right? And we have the side stream, and we have the ZOL. The ZOL does the IR, measure the CO2 in real time. It takes 2 minutes to fire up, whereas our GE can detect that after a quick little sample. Okay, so end-tidal CO2 problems. You can have this DOPES acronym here. That is what's used also when you have a alarm firing off on the ventilator. You're always thinking DOPES. You're thinking, is the tube displaced? That's the first thing you should look at. Is my tube in place, right? So you look at the machine at the monitor. Oh, yeah, I got tidal volume. Exhaled is different than my inhaled. And look, it says percent leak, 83%. And then you look at the patient, the AT tube is like halfway out, right? So looking and see there's a tube displaced. And those other things we can look at as well. Look to see if the volumes are appropriate. The machine will tell you that as well. We can look at obstruction patterns, and we'll talk about peak pressures and plateau pressures in our next lecture, where you can assess if they are in the right place or not, right? Pneumothorax is also a worst case scenario. And then, is the equipment functioning? Is it actually doing what it needs to do? And are there stacked breaths? Stacked breaths is going to cause what happen? It's cause my baseline to start trending up. Okay, so if there's a gas leak, that's a problem. That means they're not delivering enough O2 to the patient, and you're going to see the leak there, or they bit through their cuff, for instance. You're not going to get a complete waveform. There's going to be some drop in the waveform, right? We should be seeing a nice, our usual shape we're used to, right? If there's no waveform after that, it could be displaced, or they could have gone into cardiac arrest. Something is wrong, right? So we got to figure out what it is so we can get that flow of CO2 to measure on the bedside monitor. So cuff leak, ET2 is perforated. There's a reason why there's not gas being picked up. Okay, so severe DOPES, right? They lost the waveform because of displacement, an obstruction of some sort, a severe pneumothorax, right? Especially like a tension pneumothorax, that's going to do what? What's different than pneumothorax and tension pneumothorax? Not bleeding, that's hemothorax. Pneumothorax can cause tension on the great vessels and lower my cardiac output, and that's going to be, I can see that on end-tidal CO2. My cardiac, it's like, oh yeah, they're here for pneumothorax, they got a chest tube, and then you see your end-tidal CO2 start trending down and down and down. Like, hey, they're on the ventilator at 16 breaths a minute. Why is my end-tidal CO2 going down? It could be a tension pneumothorax that's developing. All right, equipment problems. So we got to, you call an RT over to kind of help troubleshoot as well. Okay, if you have a flat end-tidal CO2, sometimes it's expected in brain death. If your brain is dead, are you sending signals to breathe? No. So do you expect, that's hypoventilation, so why isn't it elevated? Because you're not breathing, right? So there's no end-tidal CO2 to pick up because you're not breathing CO2 out to be picked up, right? Yeah, when I hook them back to the ventilator, I'm going to see a little higher end-tidal CO2 because the ventilator is going to deliver the breath. But apnea testing, that's a perfect way to see, yep, they're apneic, they're not breathing in brain death. And then cardiopulmonary arrest, you're going to see this drop in your waveform. It might be over time. See right there, it can trend it down. And yeah, that's a situation. I'm going to check my patient, make sure they still have a pulse at this point. Anything less than what number is I would want to check a pulse? Less than 20 means you have poor cardiac output, right? So it's time to check a pulse at that point. So during arrest and during ROSC, right? So cardiac arrest is sudden loss of waveform or a downtrend in it, especially less than 20, right? Means there's inadequate perfusion. Sometimes you'll see patients with an end-tidal CO2 of 16 and they still have like a weak pulse, but those patients we probably are on 2-3 pressors at that point, and we can kind of track it and try to fix it. And someone comes along and says, let's do bicarb push. Look, it went up to 24. It's because of the bicarb. It's not because we improved the perfusion. Okay, so goal during CPR is again 8 to 10 breaths. Sorry, 8 to 10 on your end-tidal CO2, and that is that means adequate CPR is being done. Okay, if that's not the case, we got to maybe change compressors. They're getting weak, and then also end-tidal CO2 is great because it gives us valid numbers from all the cardiac arrests that happen. We can see, hey, the end-tidal CO2 is less than 10, right, which is expected with CPR, and it's been 20 minutes. It's officially, you can say like with 99% certainty that it's futile, right? There's a very, very small chance they do get a pulse back, and if they do get a pulse back with an end-tidal less than 10 for more than 20 minutes, the outcomes even then are horrible. They're not going to be leaving the hospital, right? So that does happen. You see your like 42-minute arrests, but that's not, if it's end-tidal CO2 is less than 10, that is not usually a sustainable thing as a futile efforts. But if your end-tidal CO2 is greater than 20, during the arrest, you're like, well, shoot, it's greater than 20 every single time I do a pulse check, and when I do compression, it's like 18 to 22, right? That is a salvageable patient, right? Like this guy right here came in full cardiac arrest, right? And they measures end-tidal CO2, and he wasn't 10, he was sitting about 20 the whole time. They're doing cardiac arrest, right? You keep going to VTAC, out of VTAC, in VTAC. Here's them having VTAC storming, right? So they did CPR on them for how long do you think?
40 minutes.
96 minutes, right? You had a 96-minute arrest. So they didn't give up because they knew the data supports as long as you have an end-tidal greater than 20, you can continue CPR. It's not a good sign when end-tidal is 22 and on pulse check and like, oh, let's call it. It's like, no, they still have a pulse, right? There's still things we can do. Let's get someone else to see if there's something fancy they can do, right? There's other medication strategies you can do. VT storming, you can put 2 Zols on the patient and shock them twice. Don't do it unless someone's supervising you, because if you overlap them, you can destroy the other Zol, and it's like a $20,000 machine. So you just got to do it with someone who knows how to do it, and then you can do that. You can replace things around. You can give you can do stack shocks. There's all kinds of things you can do with someone like that's VT storming like that. And then also there's things we can do if we're at a center that does ECMO. You can put them on VV ECMO, and now you can circulate their blood while their heart goes to VTAC. So I'll take over right now. Let's just circulate your blood out here, right? So there's all kinds of things we can do with someone who has an end-tidal greater than 20 for more than 20 minutes. If it's less than 10, it's not salvageable. Okay. So how do we know we have ROSC? That's when we have an end-tidal CO2 greater than 14, right? Greater than 14-point jump. So here we have a end-tidal CO2 of 10, right? And they jumped up to 45. Well, shoot, that's a great ROSC, right? This guy right here is at 10, and he went up to like 35, right? So that's telling us that he was doing great compressions here, right? He was doing the 2 to 4 centimeters or inches, sorry, and then that will then cause we can see right there. Oh, you're doing great compressions, right? You can even see the rate on the monitor; it'll tell you the rate. Okay, but once you have that rise in 14, that's going to tell you that you have ROSC at that point. Okay, and decreasing amplitude. So notice this amplitude right here is getting lower and lower and lower and lower. So what's going on? It's getting less than 35. What's happening?
Cardiac output.
Could be cardiac output that's dropping. Good. What else is it? What it tell? Could be PE, like poor cardiac output. What else? Can be someone that is hyper or hypoventilating. Hyperventilating, right? The CO2 is going down because they're hyperventilating. So here's our borderline here of 40, and we're going down and down and down and down, right? So we are hyperventilating. Yeah, it could be dropping cardiac output. We got to think of both. Like what blood pressure is 170 over 102? Probably not blood pressure, right? So I'm going to look to say, are you breathing fast? Yeah, you just came in end-stage renal disease. You have fluid all in your lungs. That kind of makes sense why you're breathing fast, because you're probably hypoxic, right? So they're hyperventilation. They have some SNS stimulant that's making them breathe fast, right? They're hypoglycemic. They're hyperglycemic because they're dehydrated. They have elevated CO2 maybe, like a hypercapnia. I put that in parentheses because usually you would see that on the end-tidal CO2. But definitely you're hypoxic for some reason. Your pH is going down. You have a urosepsis, right? And again, like you said, the BP starts going down. They're going to start breathing fast at first, right? And this is compensation. You want to monitor that, right? End-tidal CO2 is going down 35, 30, 28, and all of a sudden it starts going up to 30, 35, 40, 45. Oh, they're perfect. It's like, well, they might be getting weak on the respirations, right? They might be tiring out, right? So pain, agitation, again, SNS stimulation, drug ingestions, right? That we get someone, they'll take meth, right? Where they're mething some teeth, and they get cocaine as an SNS stimulant that will raise the respiratory rate and therefore blow off more CO2. Right? And like you mentioned, decreasing cardiac output to the lungs, a PE, heart failure, and impending arrest, that could also be a situation to monitor when your end-tidal CO2 is less than 35. Okay? And the metabolism, they're hypothermic, they're hypothyroid. These are things that can cause a decrease in respiration to tidal volume, or they got medications that's going to be on the next slide, right? When they're hypercapnic, when they're hypoventilating with medications. But in this case, they're in a myxedema coma where they are not producing CO2. So the respiratory tidal volume is going to cause a hypercapnia, right? If it gets to that point. And alveolar hyperventilation. This is sometimes you have too much PEEP that can decrease the flow of blood to the lungs, and that can be a reason that we cause, that we maybe come back down on the PEEP. Okay, so why would it be greater than 45? Most commonly, they're hypoventilating. They're not breathing fast. So they're over sedation post-procedure. Their mental status is decreased. Either have a head trauma, post-ictal, a neuro patient due to respiratory drive being knocked out, or they ingested drugs, such as what kind of drug might knock out the respiratory drive?
Opiates.
Yeah, opiates, a fentanyl, or extra pain medications, or propofol via a licensed physician with no airway. That would do it as well. Okay, increased metabolism. That will increase your production of CO2 just independently on its own, like a hyperthyroid patient. A bicarb push we mentioned, it just produces CO2, and then you're going to blow it out, right? And then we have other reasons like overfeeding that could cause a rise in CO2, right? Sometimes they come back post-op XLAP. They inject CO2 gas into the belly so they can see what they're doing. And post-op, you might see the CO2 go up because of that reason. Okay, and COPD patients, they do have a higher baseline. So just FY, you can calculate what the baseline should be, right? So their CO2 the bicarb is like 35. You can say, well, I can guess what your CO2 should be at on the ABG, right? And of course, the end-tidal CO2 will trend behind it. So having that information can tell you if we're in the right place or not, right? So let's just say the end-tidal CO2 CO2, PA CO2 on the ABG is 36, right? So 36, did I say PA CO2? The 36 bicarb, right? So we have a bicarb at 36, so we can estimate what their CO2 should be, right? So you take 36, 1.5 times it, that's just 50% more, right? And then we have plus 8, right? What's 36 times 1.5 plus 8?
54.
54 plus or minus 2. That's where they should live, 52 to 56. So I'm going to take that. That's okay. My ABG shows 52 to 56. That is where they should be, right? And your end-tidal CO2 at that time will tell you, and then you can track and trend it. If the end-tidal CO2 starts going up and up and up, that means they might be developing too much CO2. And the danger is on the other side. If we think the CO2 is too low and correct it, they're going to stop breathing to compensate for the high bicarb, for the alkalosis. And your COPD patients, they have this emphysematous pattern, right? They exhale completely, and then their lungs collapse right there, right at the distal bronchus, and they trap the air for one, but also they can't get any further breath, right? We expect our end-tidal CO2 to kind of rise just a little bit. All right, so bronchospasm, so other scenarios. So we talked about the shark fin, right? So our shark fin appearance right here, that is a sign of bronchospasm, where the air can't get out nice and easy, right? Nice and easy, like whoosh, nice and easy. Whereas I'm having difficulty getting out, it's going to be a sharp upstroke, but it's going to be flatter. I guess not the best way to say that. It's a sharp shark fin, but it's it's kind of fallen. See how the slope has fallen there compared to the slope right here. See how they're different in angle, right? So that sharp angle like that, or that more acute angle, is going to be a reason for considering bronchospasm. Okay, has a shark fin appearance. All right, difficult getting the air out of the lungs. You can tell if you're in the right main stem. You don't have to wait for an X-ray. You can just say, hey, let's pull back the ET tube a little bit, right? Because if I have my ET tubes down here, this CO2 comes out and says, oh, there I am, right? And then this CO2 is like, wait for me, right? And then you're going to get a little extra CO2 at the end, right? So you can see you should not have a waveform with a little dip in at the top, right? The only reason for that is two reasons, primarily. A, they're on neuromuscular blockade agents, or B, your right main stem intubation. Sometimes you'll see this pattern. I've not seen this yet with cardiac oscillations, like really, really bad CHF. Sometimes with pregnant patients or patients with ascites, they'll have a little dip at the end, right? They exhale, and then the baby pumps down, and then they get a little extra squeeze at the end. Sometimes that happens. Like I mentioned before, it's the coffee cup rule. So if you think of this little top hat, your coffee cup should sit on top. If it's about to fall off like that, that is a problem. All right, it should be able to sit nice and easy on top. All right, so why measure end-tidal CO2 for someone? Why can't I just use the pulse ox? Well, that would tell me how they're ventilating. It absolutely won't, right? So it can tell you that if you ventilate and you get oxygen in, you should get a rise in your pulse ox, right? Your pulse ox should sustain. But what if there's differences, there's delays. Like there's a person has a 13-second apnea period, right? I'm not sure if you ever watched someone breathe in at night, a night shift. It's like, why are you watching me sleep? But anyways, you say you watch them and you see they stop breathing because they've been snoring for a storm beforehand, and then you see your pulse ox, and it won't be till 13 seconds, sometimes 20 seconds later before they kick back in, and it triggers them to take another breath, right? Hypercapnia or CO2 actually will rise first and will trigger your brain to fire off more than oxygen will, right? So you can't use pulse ox reliably in that situation. Also, if you feel that your pulse ox is falling like that, it is very, very precipitous, right? If they truly are hypoxic, it's literally a roller coaster. As we mentioned, the O2 hemoglobin dissociation curve, our favorite, right? So you should be about 88%, but it's a very, very steep drop, right? If they stop breathing, the pulse ox is 88, 86, and then now you're already behind the ball, right? And who's most at risk? Someone who's like morbidly obese, right? If you're on your roller coaster, they have a huge belly that's getting in the way, right? You got a third trimester person, you got a very drunk person that's vomiting. That's going to make their stats drop even quicker, right? A COPD patient's packing their own O2 tank and is breathless, walking 3 feet. That's going to be someone that's going to drop their O2 very, very quick. Right? So during RSI, though, for these patients, you do want to provide oxygen. All right, this is called apneic oxygenation, which we're probably going to talk about on our next lecture. Right? When they're apneic, when you're intubating them, you want to provide oxygen. You want to provide this oxygen to your cells, so they have oxygen to bleed off of. Not only the PO2, but also your saturation. They want to be nice and saturated, so you have a good, 2 to 5 minutes brief period where you can support their oxygenation. Right? Good position can also help someone that is really obese or has other issues. Okay, so end-tidal CO2 again is very useful to kind of track someone who is hypoxic, who is hyperventilating beforehand. We can see afterwards that we want to keep the end-tidal CO2 probably on the lower side because they're probably breathing fast to support the hypoxia. And if they have, they're not breathing fast anymore, that can cause acidosis. And if they're already acidotic from like a metabolic process, that's going to compound things and make things even worse. Okay, so you want to keep end-tidal CO2 at the baseline, so you're not capturing worsening acidosis. All right, so let's do a quick practice, and then we'll be done. So we got end-tidal CO2s. We got how many end-tidal CO2s? And we'll split up and go over them, and then we'll be done. Okay. All right, so you're giving me the waveform, what's going on, if it's a weird waveform, and you're giving me at least 2 causes of why that waveform is the way it is. Okay. All right. So who has number 1?
Is this a reversed waveform?
No, it's an end tidal. Some of these are like over trends, so you can see like over 5 minutes. Like the scale is might not be
Okay,
the
gotcha.
same in each one.
So this would just be then a normal,
We can't say it's normal because this is 45,
correct.
so it's greater than 45. So why would you have an end tidal CO2 greater than 45?
Hyperventilation.
So you'd be hypoventilation, right? So like 1 breath, maybe 2 breaths, maybe, and that's why that is high. Another fringe case could be, it could be hyperthyroid, right? And they're making more CO2. They got a bicarb push. They have a fever. These could make them, make it be high. But you'd expect this to be a little faster, like someone over here, right? You'd expect, like number 6, you expect a little faster rate if someone has a fever or such.
Outside of the 45, that would be like a normal waveform morphology.
Oh, I see what you're saying. So waveform morphology is the waveform's fine,
Okay.
but as far as like what is going on there, that's a elevated end tidal CO2.
Okay, gotcha.
All right. So yeah. So hypoventilation could do it, right? A COPD with a CO2 retainer, someone that's has that's shivering, okay, and a bicarb administration. All these things can raise your CO2. All right. What about number 2?
This is bad morphology. So no hat, dislodgement.
Yep, we got no hat here. Well, it can, and the teacup can still sit there, but that is not a good sign. We have a flat waveform. So what can that mean?
Lack of ventilation somehow.
So lack of ventilation. They stopped. It became disconnected ET tube. What else?
It could be dead.
They could be dead. All right. They could have they post ROSC or not post ROSC, but anti ROSC. Right. So they had no return of spontaneous circulation. So they were it's dead. Right. Or it could be like apnea testing. When we do apnea testing for brain death, this would be a positive brain death sign that there was no ventilation that happened. There was no signal sent down from the brain to the lungs to breathe because the brain is dead. Okay. And then number 3.
It's like a pretty pronounced shark fin.
Yeah, so there's like classic shark fin. See how that angle is different than this angle, right? The number 4, right? So that is a shark fin appearance. So what does that tell us that's going on?
Bronchospasm. Some kind
Good,
of
it's bronchospasm. So who gets bronchospasmed?
asthmatics.
Asthmatics, COPDers very commonly, right? It could be someone with angioedema after lisinopril use. It could be something that's closing up the airway. Epiglottitis in a kid. Okay. Also important to just be the tube is kinked, right? Giving a breathing treatment to a kinked tube is not going to help. Just saying, right? And number 4, what's going on there?
That's like a top hat with rising CO2 levels.
Mm-hmm.
It's quick, so maybe the minute volume's too low.
Yeah, so this is a pretty fast rate compared to this one, right? This one I would really be sold on hyperventilation for number 1. But number 4 is a fast rate, I think, with some of this stuff going on, right? Someone that is like a thyroid storm, right? They're breathing really fast, but they're producing so much CO2.
Like a Kussmaul.
Kussmaul is going to be metabolic acidosis, and you expect them to be breathing fast, blowing off CO2 to compensate for the low bicarb, right? Whereas someone with, you expect a lower waveform. If it's that in a Kussmaul patient, that's bad. But to your point that you told me by mind melds is that they could be someone that is Kussmaul respirations, but they are like the tidal volumes are getting less and less and less and less over time, right? So someone is breathing fast but poor tidal volumes, right? I'm not sure if I put that here in the item. So yeah, BMR, so fast rate, low tidal volumes. This low rate, but low tidal volumes with a fast respiration. It's like, well, does that make sense? Yeah, if you're not breathing very fast, that can raise your CO2. But this looks like a fast rate. So why would someone with a fast rate start raising their CO2? It could be someone who's breathing really fast, but the volumes are super, super tiny. All right, number 5, what's going on there?
This also looks like a shark fin.
Yep, the shark fin appearance there.
Partially obstructed airway because it's not so steep.
Good. So partially obstructed airway. We got CO2 that's greater than 45, right? This one over here didn't really have a number, right? But number 5 has a CO2 greater than 45. So they're really not getting their air out of their lungs, right? So that's pretty dangerous. So it could be, like you said, like what kind of patient might have a CO2 that's rising with a shark fin?
CKA?
Asthmatic patient definitely would be having that bronchospasm and the CO2 going up. Or if it's a partially obstructed tube, it could be anybody that's breathing slow or fast.
That's breathing
Slow. All right, if they're breathing slow, your CO2 is going to build up, right? And they have a kink tube. So that can happen in real life, right? You could be breathing slow and have a kink tube, right? It could either be them biting on it, or it could be mucus plugging. It could be something in the way, right? All right, and then number 6, what's going on there?
So we're just thinking that they're tachypnic?
Yeah, it's a fast rate, right? The end tidal CO2 looks normalish. I don't have like a low end there, right? Probably that's like 35. So it's normal end tidal CO2, but I keep an eye on it to make sure it's not going which direction. If they're breathing that fast. Make sure it's not going down or up. If you're breathing fast, you're blowing off CO2, right? So we want to make sure our waveform's not going down over time, right? Then we got to keep an eye on it to see if that's appropriate or not, right? Is there something else we can do? Are they getting more acidotic? Or are they having a more respiratory distress? Is it pain, agitation, anxiety? Okay. So they're hyperventilating. Okay. SIRS, sepsis, it could be DK as well. All right. Then number 7, what's going on there?
Is there some sort of leak going on?
It could be a leak. Yep. So they lost the waveform, and then they reattached the vent. That could be it. What else could it be? Yeah, it could be obstruction. They freed up the obstruction. I think more commonly it'd be we lost our waveform, right? And then we got, all of a sudden we increased by 14 points. What we get? We got ROSC, right? So this could be a CPR kind of situation where they start losing their cardiac output. They lost it, gone. And now we're doing CPR and then we regained it, right? A loss of waveform, so for some reason, okay? And number 8, what's that?
We were thinking either like a disconnect or maybe
Yeah, this looks like a disconnect, right? This one over here, number 7, it kind of trended down. We could see it breath to breath going down and down and down. Whereas here, it's kind of all of a sudden. Why is it? What happened? Did it just all of a sudden bite on the tube? Maybe. The next waveforms might be shark fin. But here, it just looks like we want to check to make sure they're still connected to the ventilator, right? Make sure they get like a huge mucus plug-in. All right, number 9, what's going on there? Yeah, looks like another obstruction of their tube. This was 45 before, and then now it has dropped by half. So, and they're still breathing there, maybe. It could be just a drop in cardiac output too. Maybe it's like a sudden PE that developed. All of a sudden they got a PE, all right, and then now their perfusion dropped immensely. Okay, so it's definitely, I think, more error on cardiac output, right? Unless like all of a sudden they started breathing fast. It doesn't really make much sense. Like, why were they breathing fine before and now they're just really breathing really quick? Okay, so an obstructive pattern. It dropped right away. So yeah, it does look a little shark finny, but the immediate drop in cardiac output is kind of like what we're leaning more towards. Number 10, what's happening there?
maybe like a little hypoventilation, a little low.
Mm-hmm. It depends what this number is. Yeah, so it could like a low, it could be hypoventilation because it looks like a slow rate here. And then as you have a slow rate, you do go up over time, right? Which you're seeing the hypercapnia happening. But it could also be like a ROSC situation, and we're just doing breaths, 6 to 8 breaths per minute, right? That could be what's going on too, because we have to know what this number is right here. If that's like 8 to 10, we're ROSC territory. If we're like 25 to 30, then we're breathing, and they're breathing slow. That 25 to 30 is going to be 30 to 35. It's going to be 40 to 45. It's going to start going up and up and up. Hasn't really hit 45 just yet. All right, and then what else? Number 11. Yeah, that looks like a ROSC right there, right? We don't have a really number right here, but it looks low, right? It could be low cardiac output, and all of a sudden someone, give a little bolus suppress, which you're not supposed to do, or they get someone or they got, they got a jump, like maybe they had a AFib RVR, they had a low blood pressure, and all of a sudden you cardioverted, and then they converted back over, right? And then we got 12. What happened to 12? Normal. That's it. Normal end tidal CO2. Right? We're 35 to 45. Unlike number 6, we really can't. You know, it looks like a little fast in that one. Whereas number 12 looks like a normal rate. Right? All right. Number 13.
Another Ross.
Good. Another ROSC here. Right? So we had definitely less than 20. Right, on our CPR, and then we have a big jump in our end tidal CO2. Reason for that is either an increase in blood pressure for some reason, most likely a code situation. Okay, and then 14. What happened with 14? It tells you right here. It's dropping gradually. Why?
I'm thinking maybe the ET2 was displaced.
If it's like fully displaced, you'd see a lack of, it would just go away.
Cardiac output.
Good, a decreased cardiac output for sure, right? Cardiac output's going down, 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 and then if it gets less than 20, we're kind of trying to assess for a pulse. But also, this could be someone who's breathing fast, right? It's over 15 seconds, and it went down. It could be someone like really, really crashing, or it could be someone just breathing really fast, right? It says respiratory rate 22 right there. I probably wouldn't go down that fast if they're doing 22, but if they're like 32, yeah, I expect that to start dropping real quick. And number 15.
Air trapping.
Good. So we got the CO2 not return to baseline. Right, here's baseline. The other ones, you see the CO2 going up and up. That means you're not getting rid of every breath. Right? And this can lead to a drop in your blood pressure because all that air traps, and it impairs venous return to the heart. And you get a drop in your blood pressure. All right, and then we got 16. What happens? What's with 16? Normal. That's a normal end tidal CO2, 37. Right? There's no trend here. It's perfect. Right? What about 17? 5 out of 5 stars on Yelp. Right? So what is number 17? Looks like an arrest because it looks like it's stolen from the other slide that said things about arrest, right? So, but yeah, end tidal CO2 is less than 20, got poor perfusion, and maybe you make a little bicarb push real quick just to, to appease the gods. And then, or we were doing CPR, and then we got ROSC, right? Usually it's a 14-point elevation, and usually you're above 30. And it doesn't look, maybe that's 30. It's hard to tell. Okay. So then what else? Number 18. Yeah, neuromuscular blockade. They're not adequately paralyzed, right? Or they're coming off paralytics. So the vent's doing all the work for them, and they're trying to take little baby breaths on top of that. So you can actually see them take a little inhalation effort, right? As they draw gas in, they draw O2 in, you're not going to have CO2, right? So that's a little dip right there.
Could that be any desynchrony?
Maybe, yeah. Can you see? You're going to definitely see some abnormal waveforms, and they're desynchronous. But it's like pretty textbook where they're kind of coming right back in as the ventilator is doing its thing. All right, number 19. That's different. That's 2 breaths compared to the other ones that have like at least 4 or 5 breaths, right? So that CO2 is going up and it's more than 45. So this is someone that's hypoventilating, right? And what's another cause? What would cause hypoventilation?
Over-sedation.
Over-sedation, good. All right, they got too much sedation on board. There could be something neuro happening. All right, narcotics. Okay, so number 20, what's going with that? That's a shark fin appearance compared to this one, right? So shark fin appearance means you have what going on? We got bronchospasm, right? And end tidal CO2 is all the way up to like 60 there. So that's a problem. They're really trapping air. They're not trapping just yet, but they're not really getting rid of a lot of CO2. They're probably struggling. So it could be like an asthmatic, right? Which is pretty bad if it's end tidal CO2 is 60, right? Or it could just be someone that's a CO2 retainer that is just biting their tube. It's like, stop it. Okay. And then 21. What do you got with 21? Maybe obstruction. Obstruction would be more like the shark fin appearance, but this one looks like it's we lost the waveform at the very end. So this could be a leak, right? So the ET tube should be cuffed and it should make a nice seal. So we shouldn't be losing a lot of volume. But if the cuff is down and the inhalation is just fine and exhale, and then some of it just leaks around, right? That'd be a cuff leak or a gas leak like in the OR. Okay. All right. And 22.
Increase in end tidal CO2.
Yeah, CO2 is going up, right? This looks like pretty slow breaths, right? So they're hypoventilating, right? So any reason for hypoventilation? Give me one. Oversedation. Good. It's too much narcotics. They have the ventilator rate is too high or too low? Too low. The tidal volume is too low or too high on the vent?
It is too low.
Too low as well, right? Any one of those will make you hypoventilate. All right, 23. Yeah, something happened there. They bit on the tube, mucus plug happened, they got bronchospasm all of a sudden, so we can give bronchodilators, or we can tell them to stop, or we can, we may have to do some suctioning. 24. Good, so it's going down, right? So what would cause that? Good, decreasing cardiac output. They got a PE happening, so they could be also, if it's going down, are they breathing fast or slow? Breathing fast. We'd have to have the rescue rate really to assess, right? We can't really tell from this, but yeah, so it's either one of those two things. And then 25.
We're thinking right mainstem.
Good, this is like unique to right main stem, right? That shows that there's, the CO2 goes up the right main stem all the way up to the sensor, and then the left main stem contributes its CO2 right after. So it's kind of disjointed and separated. All right, so that's end-tidal CO2.